when you're putting your sun cream all over your face and your fingers have got a little bit left over, tapping it on your eyelids. I mean, putting large amounts in will run in your eye. It's really irritating. And there are lots of formulations these days that are thinner and easier to use, and are quite often recommended by Sun Cancer Australia, recommendations. Hat and sunglasses are critical. Australia's sun is very harsh, and the other thing to know is if you've had a skin cancer, the skin just next to it is as much risk of transforming to that next step of going to dysplasia or malignant transformation. So if you have any concerning lesion, particularly if you've had a skin cancer before in your face, really important to get in early and minimize surgery that might need to happen. And maybe a biased opinion, but I do think the eyelids are best managed by oculoplastic surgeons, and there is a bunch in Australia and New Zealand who belong to a society called Anne's office, where we've often had overseas training specifically in the delicate tissues around the periocular region. We only deal with that tissue rather than top to toe plastic surgery.
Eyelid concerns are incredibly common. Drooping lids, watery eyes, lashes turning in, lids turning out, and even small lesions that slowly grow over time. Some people assume these are just cosmetic issues. Others ignore the symptoms for years, but the eyelids play a critical role in protecting vision and maintaining eye health. In this video, we're unpacking the difference between cosmetic and functional eyelid surgery, common eyelid conditions, and when it's time to see a specialist. I'm joined by Dr. Freny Kalapesi from Eagle Eye Surgeons. Dr. Kalapesi is an experienced ophthalmologist with subspecialty expertise in oculoplastic and eyelid surgery, managing both functional and cosmetic eyelid conditions. But first, for those who don't know me, my name's Paul Salloway, founder of Optics Digital. We help connect eye care professionals to their communities through patient education. So hi, Freny, and welcome to the Eagle Eye Surgeons YouTube channel.
Thanks for having me, Paul, and for your time.
So would you like to give us the mandatory brief background about yourself and what drew you into eyelid and oculoplastic surgery?
Yeah, sure. So I'm local. I was schooled in Wollongong and then came to Sydney for my high school. I did my undergraduate degree at UNSW in Sydney. I did my internship at Westmead and then my resident year at Prince of Wales. And around this period, I was interested in surgery, wasn't quite sure which field, and did one of my resident terms in ophthalmology and loved it. And so I started trying to gear myself towards ophthalmology. It's a pretty hard career to get into, unfortunately. And so, along with after my resident year, I started doing a PhD in basic science in ophthalmology, looking at neuroprotection. And I assisted a private oculoplastic surgeon, which probably drew me to the subspecialty at the time, as well as doing 3 other part-time jobs in emergency, one night after hours, and some private hospital night shifts to help pay the bills. And then I got in and trained predominantly at Prince of Wales Hospital with some peripheral rotations, including Sydney Eye Hospital and Broken Hill and some other things. When I completed, I did 2 years further fellowship training in the United Kingdom, specifically with some extra training in eyelid, lacrimal, which means tear duct and orbit surgery. And since I've been back, I've been predominantly practicing privately, though I do have a public component at Westmead Hospital, and I've been working in and around Sydney since 2012. I've been in this region in the sort of northern beaches and now lower North Shore since 2012, and in the Mossman vicinity since 2023. And I've recently joined Eagle Eye Surgery, which is a brand new fully decked ophthalmology clinic on the lower North Shore, and excited to be here.
All right, thank you very much. Well, so Freny, blepharoplasty, it's probably not a term that gets thrown around at the weekend barbecues too much, but for people who have heard the term before, they probably think of cosmetic surgery. So what is blepharoplasty really? And is it all just upper eyelid surgery, or is there more to it than that?
Yeah, so blepharoplasty is essentially, like, bleph means eyelid, I think in Greek, and plasty means remodeling of anything. So it's essentially removing usually excessive skin that hangs over the eyelids or is just even a small fold there if people don't like it, and also repositioning or reducing some of the fat pads. So they tend to, as we get older, prolapse through the structures that hold it back, and we can get little lumps around the eyelids that sometimes people don't like. Predominantly, most people refer to the upper lids, but there are people around who are aware of both extra skin and or fat pad prolapse of the lower lids. In terms of whether it's cosmetic or functional, look, it's a bit of both, to be quite frank. And, you know, definitely functional when it interferes with vision and thoughts, and people are using their brows all day long to lift up their lids. And when they get tired or fatigued, it does hang in their way and give them both a feeling of heaviness as well as a look of heaviness and tiredness. And so it has both a cosmetic and functional slant. When we're addressing patients for blepharoplasty surgery, there are two things we as doctors or surgeons need to keep in mind. One is the medical benefit schedule, which is called MBS for short, and it's what governs whether the patient is eligible for a rebate, and that's a functional disease really. So they have to have a visual field deficit or have some inflammation or irritation from skin on skin rub, sometimes like how people get it in the axilla or underarms or neck or things like that, so it's just irritating. And so that will authenticate an item number rebate. And if you get an item number rebate, then it allows patients to dip into their health fund if they have one. APRA, who is the governing body for all kind of medical, paramedical professionals, has also in mid-2023 mandated a set of rules basically to try and make it a safer space for patients navigating and to try and prevent bad patient outcomes. There was a spate of media happening around mid-2023 when this all happened, and basically we have to assess patients as having being suitable for surgery. You know, they don't want to be Barbie. We need to exclude something called body dysmorphic syndrome. We have to kind of consult with the patient twice, which allows us to talk to them, give them all the information, disseminate information, answer questions, and let them go away, have a cooling off period where they can talk to friends and family, you know, look up the internet, get some advice, read our pamphlets, come back armed with some questions, and then they consider this information and have the opportunity to cancel. And also, we have to do surgery in accredited day surgery, which unfortunately means that the cost has increased. And it was a way of basically making sure you get an accredited surgeon rather than a doctor with an interest in cosmetics who isn't allowed to operate in the private hospital field. Generally, I mean, maybe I'm biased, but I think blepharoplasty should be carried out by an oculoplastic surgeon who's an ophthalmologist specifically trained after doing ophthalmology in surgery around the periocular region, and they know maybe the layers of the eyelid, you know, to finitum, and it allows us to assess whether anything extra needs to be done. So sometimes we lift the lids. So blepharoplasty surgery, as we said, is taking some stuff off, but essentially, you know, I've got, you know, if you look at me, hopefully my lower lids are skirting the coloured part of my eye, and the top lid is just slightly hanging over the coloured part of my eye. I've got a little picture here you may or may not be able to see, but that's pretty normal. Yeah. So if the eyelid is instead, you know, slightly low or impinging on the pupil, or even more so, and we want to lift it out of the way, not that high, we don't want to see the white, but that's called a ptosis repair, and that's actually addressing a muscle inside the eyelid and shortening it. And we do that with the patient a week so we can kind of gauge where we want to set the eyelid height. And this is often something I do on not most, but a lot of the patients who are seeking blepharoplasty surgery actually end up having a concurrent ptosis. And occasionally when the brow is too low, which happens as well when we age, it pushes all the skin into a smaller place. And if you just did a blepharoplasty, you sometimes remove it really too much important tissue, and it still looks tired and weird and older. I mean, you don't want to lift it too high, it can look like a clown, but a little bit of a brow lift or stabilization accompanied by this sometimes required. So I think having all of this information on board and assessment by an oculoplastic surgeon is important, and someone armed in all those areas. And also, one thing I would say to patients who are coming in for a consult is don't have your Botox in 2 or 3 months coming up to the consult. Not everyone has it, but it's more and more common these days. And if we don't ask, we don't find out that people do it to settle the wrinkles here, and then they can't lift properly and everything drops and they get, you know, artificial looking skin there, which if we do is too much. And some people do it around the eyelids to lift the brows and make it look like they don't need a blepharoplasty. And if they come in then, we might take too little and then it wears off and they're not happy with the results. So I think that's important to just flag to patients these days.
So is blepharoplasty a major surgery? What does the recovery period look like, and what are the potential risks involved in this kind of surgery?
Yeah, so I mean, I wouldn't say it's a major criteria. I mean, prior to the advent of APRA, for people who didn't have a health fund, we could often even do it in the rooms if it's just skin reduction and we're not going deep into the fat. But now that and so we often do the fat, which is deeper, and that has slightly higher risks if it's had an uncontrolled bleed. But I would say it's day surgery procedure and a local anesthetic and day surgery facility with a bit of sedation. You go home the same day. You could expect to have some bruising for 1 to 2 weeks. You sort of go through the purple, and then by about 2 weeks you might be in a brown or yellow phase of bruising. Most swelling goes down as well within this 2 period, but there is an element of puffiness or thickness in the lids which can persist for longer that most people may not know is there, but you as a patient and me as a surgeon can detect. There can be a feeling of numbness in the lashes. The risks of surgery in my hands are rare, but we can potentially overdo surgery. It's pretty rare because I do all my measurements with your eyelids closed and do a pinch test as well. Temporarily after surgery, you can feel a bit dry if it's swollen, you're not blinking properly. We cover people with drops for that. Underdoing is more common because patients look at themselves with their eyes open, of course, and so they can feel that you could have taken more, but it's really important that we protect the eye and leave enough skin that blink is natural and comfortable. And then in terms of getting back to everyday activity, you can work and drive as soon as the sedation's worn off. You might have a purple bruise look to your eyelid, so as long as you're happy to wear that on show. But I would protect yourself from things that might induce an infection, such as swimming pools, or if your job's a plumber or cleaner, even things like heavy lifting to reduce the wound coming apart or dehiscing. And again, no makeup for a couple of weeks after, probably 2 or 3 weeks, just to protect yourself against infection.
So you mentioned that in a lot of cases, people come to you because of cosmetic motivations, but you've mentioned a few cases where there are where this could actually cause functional issues with vision. So, like you mentioned, driving. Are there any other sort of like functional problems that people might experience from drooping upper
Yeah,
eyelids?
so using the brows all day long, they can get headaches towards the evenings, and they
Yeah.
typically will say that it's worse towards the end of the day. I mean, there is a condition where it's very fluctuating. They can get ptosis one day, not the other day, and that's a systemic disorder. We sometimes ask the appropriate questions and need be send them off a blood test, but most times it's fatigue towards the end of the day or tiredness and the feeling of peripheral hooding or limited peripheral vision, which we
Mm.
can test formally with visual field testing.
Okay. Well, another topic I'd like to ask you about, and that is entropion. So, can you tell us what that is, firstly? Are we talking about a condition that affects mostly the lower eyelid? And if
Correct.
so, what happens and why is it a problem?
Yeah, so entropion usually refers to rolling in of the lower lid, although very rarely it can affect the upper lid. That's much less frequent. And it's a very irritating and much more functional condition, I'd say, than what we've just discussed, because the entire lid and lashes are rubbing on the eye. And this could just be like the lower part of your eye, the white part, and cause irritation and redness and watering. But it can even be higher through like the cornea or, affect vision, and you can get scarring there. And if scarring progresses, even ulceration and the risk of infection. So it is a really troublesome problem to patients, and one we want to rectify for them quickly.
So, is this something that also can gradually happen to us through age?
Usually, yeah, usually it is an related problem we call involution or kind of weakening of the supporting structures of the eyelid, the ones that both lift the eyelid vertically and horizontally. Much more common in people who are eye rubbers or blinkers
Mm.
frequently. In Australia, a lot of the tightening of the skin means the eyelid might go the other way, but we find people who suffer from allergies or wear contacts and are frequently irritated, they might be squeezing more, and it gives them more of a tendency to roll in rather than rolling out. It can occasionally result from some scarring, which can be
Mm.
either due to unusual infections such as trachoma or even inflammation.
And so I'm imagining that a lot of people with this condition are using lubricating eye drops. Is that a satisfactory long-term solution, or does it usually require surgery?
Look, it's a great first step because it's like WD-40 on your joints of your door, especially the thicker you go and you're using gels rather than drops.
Yeah.
or even ointments. It's a barrier, and it, reduces the rub of the lashes and the lid on the eyeball to relieve the symptoms and the signs that we see. But really, it's not a longer term fix, and the problem is there, and we need to kind of try and do something about that lid position. So there are options, both office-based temporary and more definitive. And so I'd say the office-based temporary, two things we can do. One is a row of Botox injections in the lower lid, or botulinum toxin, paralyzes the muscle that wants to squeeze the eyelid in and turn and flip it in. But it's a drug, so it works and it wears off in 2 or 3 months. So not the best long-term fix unless you've got a patient in palliative care, or someone who's too frail or elderly to come in for a little procedure. There is another office-based procedure that works really well, and we just, no cutting, just do a row of stitches from inside the lower lid and tie the knots underneath the eyelashes, and it creates a little bit of scarring. We leave those sutures to dissolve naturally. Try not to get the GP or someone to cut it out helpfully, because that creates that enough scarring that will hold the lid out. And we traditionally get taught it lasts for about 6 months to 18 months. I've had a patient who came back 7 years later and it was just worn off. So if you put more sutures in, it can sometimes hold them for longer. But again, that's probably reserved for your frailer patients or someone who's really not wanting surgery, because the surgical fix is fairly a simple, 30 to 45-minute procedure in usually a day surgery facility, where we're tightening the lid horizontally as well as the muscle that has got loose, and tightening that vertically as well.
Okay. Well, at this point, I'd just like to say that if you're watching this on YouTube and you find this video helpful so far, then please do us a big favor and hit the like button. It really helps us out with the algorithm and increases the chances that others will find this source of trustworthy information about their eye health. All right, Freny, so we've talked about entropion. Now let me ask you about ectropion, which I guess the clue is in the name. This would be the flip side, is that right, of entropion? So how is it different?
Yeah, totally. And so entropion's turned in. Ectropion is when the lower lid turns out. It can also cause irritation, but it's not as severe and instant, because instead of turning in, touching the eye, it's turning out. But turning out means that the bit of the eyelid that is usually opposed to your eyeball is exposed instead to the air and the wind and dust, and it tends to get irritated and thickened and can create mucus production and irritation. People often say it's infected, but it's just irritated and thickened tissue, overproducing. And it can also cause exposure symptoms, where the lower part of your eye is getting more wind and dust and dirt and not getting lubricated with the movements of the eyelid and the blink. And so it does cause what we call exposure symptoms, or dry eye type symptoms, and watering.
So do a lot of patients like blame their watery eyes on like other factors like environmental conditions, or do they actually like attribute it back to structural issues with their actual eyelids?
Look, so most people come in when they have an ectropion, and they either complain of watery eye or an infection on the eye, and that's very common. Or they don't like the appearance of the eye if it's quite marked and the entire lid's turned out and they've noticed that. But sometimes it's quite mild, and it's usually like a problem with getting the tear to the right place, which is causing those symptoms. So it could be the eyelid's not in the right place, or just the muscles are not pumping properly and allowing the tears to go down towards the drain hole and drain away.
And so you mentioned about like mucus and that kind of build up. Are there any other sort of more serious complications if it's left untreated?
So yeah, so it causes dry eyes and watering, which can be terribly irritating. And then I guess if the lower part of the cornea is left to get dry, like an entropion, you can develop scarring there, which can impact on vision. It tends to be a slower progress rather than entropion, where those lashes and lid are imminently on the eye. This is usually the blink isn't fully lubricating the inferior half of the eye, and so you're getting dryness, which we can detect by putting a stain on the eye and having a look with some blue light. But then that can turn into scarring. And so patients come in many months or years later. Sometimes we can reposition the lid, but that scarring may persist, and then we can try and address the scarring with some steroid drops and things like that.
So that's probably a good segue to my next question for you, which is about watery eyes. I mean, it's kind of like a paradox, isn't it, that that people who have very watery eyes might be suffering from a condition that's actually described as dry eye condition. So can you just talk us through like what are some of the common causes of watery eyes and dry eyes in adults?
Yeah. So look, it's always a balance between tear production and tear drainage. So things that increase tear production is irritation. So irritation can come from dry eyes, like we
Mm,
mentioned,
mm,
or something under the eyelid. You could have inflammation. Someone who
mm,
suffers from allergy can have like regular kind of lumps that look like cobblestones on the lid and cause, the tap to turn on too fast.
mm.
Could be a foreign body or something underneath the eyelid or a little lesion. Sometimes it's just making the eye water. And then other times it's transportation of the tears, which are, flowing down generally the lower lid from lateral to medial. If that downhill vector is interfered with, so lid laxity, the lid falls down a bit or turns out a bit, then or the drain hole itself only slightly turns out, that's enough to make you water. Often the lid laxity can be contributed by a nerve palsy, someone who has a Bell's palsy or facial nerve palsy. That can be one of the vectors or pathway problems of getting the tears in the right place. And then it can also be what everyone thinks about, as everyone says, I've got a blocked tear duct, doctor. So, you could have the drain hole of the sink is medially on the lower lid. If that just gets a fine membrane over it or is scarred or closed, or is slightly, as I say to patients, on the side of the sink rather than the bottom of the sink, so it's turned out, or the drain pathway is blocked. And so we call that nasolacrimal duct obstruction. And we evaluate all of these when you come in and look up the eyes under the lids, and the lid position, and then also squirt water down, which is a bit uncomfortable, called a lacrimal syringing in the chair in the office, to work out which part of that, and sometimes multiple parts of that, are playing a role towards watery eyes.
So in a sense, you're like a plumber for the patient's eyes, is that right? And their
Totally.
tear
I
system.
do say that to them when I'm rubbing my stuff ready. Yes.
Well, so when should someone come in for an assessment rather than just relying on over-the-counter drops?
Look, so I would probably say, there's the first instance, if you have a watery eye, is try the lubricating drops. See if that reduces the reflex triggering of tears and the overproduction of tears and keeps the eye comfortable, and then your tearing is resolved. And if that's the case, well, you've kind of done your own detective work and it's dry eyes, which is very common in postmenopausal women and things like that as we get older. And so I think if the symptoms are warranting you to seek intervention. So if you're still watering despite lubricating drops, or you're on a mucus production, or you don't like the look of it, despite a trial of lubricating drops, then I would come in for an evaluation, or you can come in up front if people don't like to trial those things themselves. But often it's worth picking up a chemist over the counter dry eye lubricant, and possibly one without preservatives in case that affects you and causes more irritation.
So next question for you, and this is about eyelid cancers. So, we live in Australia in an environment where we do have a lot of UV radiation, and from what I've heard, like it's the eyelids, are a relatively small proportion of the skin on our body, but they do seem to be like they do get a an overrepresented number of cancerous lesions from what I've heard. So can you tell us more about eyelid cancers and how common are they?
Yeah, look, totally. I think from my last understanding that, eyelid skin cancers represent about 5 to 10% of overall skin cancers. And given that there's such a small surface area off the body, that's quite a lot. Most commonly, about 90% of them are basal cell carcinomas, which are probably the safest type of skin cancer to have. But there's also squamous cell carcinomas and even melanomas, which are much rarer but do happen on the eyelids, and we do see them.
Mm.
Very common in sun-exposed countries like Australia. And I think traditionally we're all taught, slip, slop, slap when I grew up in the 80s, and that was all over. But people are worried about putting creams and things near the lids. So I guess, if you do have a lesion or concern, it's really important that you do seek advice about that, or something that you don't think is right.
So what are the warning signs that someone should look for? Is it usually like visually obvious if somebody has a lesion?
Yeah, look, it may not be obvious. It might look, it's sometimes it's an overcall. It might just be a small elevated lesion, and they're quite common to get little cysts on the eyelids that
Mm.
are benign. It could be flat or slightly elevated. Often it's a non-healing lesion, so something goes away is not usually malignant if it's, or getting smaller, if it's persisting, despite maybe using some moisturizer in case it's a bit of eczema or dried skin, or if there's a change in symptoms, so it starts itching or bleeding or changing color or texture compared to the surrounding skin, if it gets smoother or little red blood vessels on the surface. Or if you lose the little hairs over there, so it's close to the lashes, sometimes people lose eyelashes, or it's further down the face, just the vellus hairs like the ones we get on the inside of our arm, the baby hairs. If they kind of go missing and it's smoother, that could be, an odd feeling that something's going on. And other rarer findings, but people don't really know about this, is what we call formication, which is a feeling of ants crawling on the skin. So if a lesion has actually been missed surface wise and has grown deeper, it can cause weird feelings and sensation if it's infiltrated a nerve. And often patients have had some cryotherapy done by the GP or been treated by Effudex or Adara, which are these topical treatments that cause inflammation and get rid of surface pre-malignant lesions. But something microscopically might have been left behind and it's grown deeper and you can't see it on the surface. So if you get some weird feelings like that, it's worth coming in for a look.
So, you hear a lot about people should go in see their dermatologist or their local doctor to get their body checked out for, moles and spots and that sort of thing. I did that last year and got a clean bill of health, thank God.
Well done.
But is that something that, like, eyelid lesions, something that your local dermatologist or GP could pick up, or does it really does it really need to be done by an ophthalmologist like yourself?
So I think exactly what you said can be picked up by your GP or dermatologist. I have no issue with them diagnosing and detecting, and in fact, we rely on them to do that. Often they will do the first step for us, which is fabulous if they do a little biopsy, but my preference is that they do what we call an incisional biopsy, where they preferably photographed it before interfering with the lesion so that I can maybe see what it looked like before, even on the patient's phone. And, if you're going to see a doctor, it's good to have evidence of what it looked like before it's been interfered with, because sometimes the biopsy will heal it nicely. It's really hard to see where and what it looked like before, especially when it comes back as a basal cell carcinoma margins involved or something like that. So it's good to both have that photographic evidence and the biopsy report. But if not, then when they come and see me, I would do an incisional biopsy, meaning I don't want to interfere with the margins, so I can go back and find exactly where it was before. And when I want to go take it out later, I will take some margins, but I would do a piece from within there and send it away, and they will tell us what it is if I'm suspicious that this is something concerning. Otherwise, sometimes we just monitor, or if it's something I think is benign, we can just take it off, or the GP can take it off. But occasionally we get surprised by the results.
So that's the diagnosis stage. So I guess the big question which a lot of people would have is, like, what does treatment actually involve and what's the recovery process like?
Yeah, so like I mentioned, I do want the margins ideally untouched. So if it comes back as saying it's malignant, then, whether it was me or someone else who did that initial stage, the excision would involve a margin. So what that means is we would take the patient, lie them down, put a pen around the lesion and add maybe a 2 millimeter, or depending on the cancer, sometimes a larger margin. And we send that specimen to the pathologist, who might be next to us as a frozen section or in a laboratory. And they will look at the margins and generally will mark them with some sutures so that they know what 12 o'clock and 3 o'clock is, or whatever, you'll mark it around a clock face sort of thing. And then they will tell us, you've got it all. Great. Okay. Or no, your deep margin or one of your radial margins, say at 2 o'clock, you've left a little bit. It's touching the margin there. And then at that point, we'd go back another time and take another frill of tissue at that area and again mark it up and have it cleared, ideally before we go back and do the repair process, which is a reconstruction of whatever layers of the eyelid plus or minus tear duct system have been sacrificed at the time of excision surgery. So obviously the earlier you get it, the less removal of important eyelid tissue and less reconstruction may need to be undergone.
So is this something that would require an overnight stay in a hospital then?
Generally, most of my surgery is not an overnight stay, like unless it's an orbital tumor or something like that, and deep, and we want to monitor the vision. Most surgery of the eyelids that we've talked about today is a day surgery stay. So you would have a sedation, and the carer would come and collect you, meaning an adult over 18 who's responsible, and then you go home, and be seen as an outpatient appointment, often 1 to 2 weeks later for suture removal.
And I'm guessing, like most medical conditions, the earlier it's diagnosed and the earlier that management begins, the better the outcomes are likely to be. Would that be fair to say?
Yeah, I mean, the smaller the surgery, therefore less recovery time and also less critical tissues removed. I mean, sometimes if it's, say, half of a lower lid, and we don't see this uncommonly, and you add a margin, or even if it's just under half and you add a margin, you end up removing really important critical tissue where you can't
Mm.
just repair it by moving tissue locally, and you have to use the upper lid to reconstruct the lower lid, keep the eyelids hinged by a flap to grow a new blood flow in, and divide it up 4 weeks later. And that's a lot of downtime for a patient. And then they're missing a row of lashes in the lower lid. And it does heal pretty well, and most patients are surprised by how well it heals and looks afterwards. And most people, they say, oh, people don't really notice it, which is great. But obviously it would have been better if it was a smaller thing in the first place and they had less of a surgical procedure and less of a abnormal appearance potentially with that reconstruction.
All right, Franny. Well, I think this has been a really helpful and certainly insightful discussion. And I think, many people maybe assume that eyelid issues are either cosmetic or minor, but as we've discussed, they can significantly affect comfort and vision and indeed long-term eye health. Is there one message that you'd like viewers to remember about eyelid concerns, and what would it be?
Yeah, look, these days, I have patients who come in and, they think of us as cosmetic doctors. They don't bring their medications in. And so I think a GP referral, the coming in with you, is really important. A list of medications and all your supplements, like your fish oils and things, that echinacea that thins your blood. And remembering, if you're coming in for upper lid surgical advice, don't play with things like botulinum toxin, which will affect your surgical results, and potentially your outcomes. And most importantly, is what we discussed last, is about the sun cancer risk in Australia, particularly. And so, when you're putting your sun cream all over your face and your fingers have got a little bit left over, tapping it on your eyelids, I mean, putting large amounts in will run in your eye. It's really irritating. And there are lots of formulations these days that are thinner and easier to use, and are quite often recommended by Sun Cancer Australia, recommendations. Hat and sunglasses are critical. Australia's sun is very harsh, and so. And the other thing to know is, if you've had a skin cancer, the skin just next to it is as much risk of transforming to that next step of going to dysplasia or malignant transformation. So if you have any concerning lesion, particularly if you've had a skin cancer before in your face, really important to get in early and minimize surgery that might need to happen. And, maybe a biased opinion, but I do think the eyelids are best managed by oculoplastic surgeons. And there is a bunch in Australia and New Zealand who belong to a society called Anne's Office, where we've often had overseas training specifically in the delicate tissues around the periocular region. We only deal with that tissue rather than top to toe plastic surgery. Yeah,
Okay.
thank you.
So where can people go if they'd like to book an appointment or learn more about eyelid surgery and treatment options at Eagle Eye Surgeons?
Yeah, so I operate for several locations, but I'm at Eagle Eye Surgery, which is in Lower North Shore in Mossman. And I mean, you can Google the clinic on eagleeyesurgeons.com.au, or if you want, you can call and make an appointment. I believe the number's 7228 3900, and you probably need a 02 before that these days.
Well, for everyone watching, if this video's clarified something for you, please hit the like button, and subscribe to the Eagle Eye Surgeons YouTube channel, and follow along for more clear, trustworthy eye health education like this. So thanks again, Franny, and thanks
Thank you,
everyone for
Paul, for
watching.
having me. Thank you.
Well, thanks everyone. See you next time. Bye bye.